Just good evening. I'm Rob Music. I'm Chief Executive of the Migraine Trust, and I'm really delighted to welcome you to this webinar with the title Understanding Migraine Treatments and Accessing Grampian Support. I've got to say, it's just wonderful to see so many of you join us tonight. Though, if I wanted to flip that around the other side, one could say it also shows there's a real need about challenges of getting the right information about migraine, despite the fact that 1 in 7 people in Scotland live with it, and hopefully you'll get a lot of what you need around that tonight. Tonight's event is the culmination of a fantastic and year-long project that has been funded by Scottish Government, looking at how to improve migraine care in NHS Grampian, with a particular focus on pharmacy as well, and you'll hear about that later on. I really hope you gain much from tonight. I am naturally biased, but I think you're going to get to hear from 3 really excellent speakers tonight. You've got Dr. David Watson, a GP with a special interest in headache. You've got consultant neurologist Dr. Callum Duncan, and pharmacist Alison Duthie. And they'll be along very, very soon. I've just got a little bit of housekeeping before we get going. All the mics and the cameras, the aim is for us to be able to make sure that they're disabled, so there's no noises happening during the presentations. Just in case yours does become unmuted, please will you remute yourself? That'd be really helpful. The webinar will be recorded, so then it can be shared again later, because we know that as well as you tonight, there were many others who also registered, so there'll be lots of others that want to see this. The question and answers session will take place after the last presentation, but please do add questions to the chat at any time. And do ensure that when you put your questions in the chat, do select the Migraine Trust as the recipient, as in the blue box that you should hopefully see in the picture below. I'm going to stop now because there's a lot to be covered, but I'm just going to hand you over to Susan first, just to talk about evaluation.
Hi everybody, so I'm just going to quickly share a very quick poll. We just want to get to know you before our talk, so if you give me 2 seconds, you will see this screen. So if you're not on your phone, you can scan the QR device, and if you are, I'm just going to put the link into your chat. And if you could take 2 minutes, it's just 4 quick questions. Like I say, we just want to get to know you. So we'll give you a minute, and then we will go back to David, who will start on his part of the presentation. Oh, fabulous. People have been able to get it. So this is great. We'll be able to see live who you are. I'll just give it another 30 seconds or so, because if you've not done it before, it is a bit tricky to get there. Perfect. I'm going to stop sharing my screen. Feel free to still access it. The link is in the chat. It just takes a minute if you're doing it, but we'll hand over to David. I'll just stop sharing.
Great. Could I get the slides up, please? So also we're getting the slides up. Just to introduce myself, I'm David Watson. I'm a GP in Aberdeen, and I have been working at Aberdeen Royal Infirmary doing the headache clinic now for almost 19 years. The idea of tonight is that I'll cover a little bit at the start about migraine, its impact on patients and families, a little bit about what happens in the brain during a migraine so that you can understand maybe some of the newer treatments. And then I'll hand over to Dr. Duncan, who's going to look at some of the treatment options. And after that, Abigail Duthie, who will talk you through a little bit of the pharmacy project and just give some advice on what your pharmacist can do to help you. We sent out a survey to a focus group of patients to find out what information they would find really helpful from our webinars. And firstly was the pathophysiology, and as you know, lots of people say, well, what actually causes migraine? Why do I have migraine? So I'll cover a little bit of that. People are very interested in managing migraine and non-pharmacological advice. So what can you do yourself in terms of triggers and options that don't necessarily taking pills and medicines? And then obviously people have a keen interest to know about what medicines are out there. You'll all be aware that there's some newer treatments that have become available in the last 2-3 years, and some really just become available just before Christmas. So Dr. Duncan's going to touch on those. And we're just going to look at some of the support groups that a lot of you will know about, for example, like the Migraine Trust who are hosting this for us tonight. So if I could get the next slide, please, that'd be great. So I think the first thing to say is migraine is a neurological condition. So we've always got to remember migraine's not just a headache, it's a neurological condition, and you have amplification of sensory pathways. In other words, the brain is more sensitive to things around you. So it's not that someone with migraine gets more light than the person who doesn't get migraine, or more noise, but their brain is more susceptible to that. And we'll talk a little bit about that in a minute. Migraine's likely to be a genetic condition, that you're born with this tendency to have migraine. So it's not your fault that you have migraine. It's a genetic tendency to get migraine. We know migraine will run in families. So not everyone we see with migraine will have a family history, but maybe 2 out of 3 people can identify a close relative with migraine. Migraine, of course, is a lifelong condition. It can have good spells and bad spells. Some people, unfortunately, are in long periods of bad spells. Some people can get some long periods of good spells. It's a spectrum condition. So some people will get mild migraine, other people get moderate, and some get very severe. So I'm lucky when I get my migraine. I get a headache that's not too bad, but I get other features of the migraine that are bothersome for me. So we actually quite often these days talk about most bothersome symptoms. So my most bothersome symptoms are the cognitive things. My brain stops functioning. I can't get my words out. I get clumsy. I drop things. And I find that if there's just too much noise in the room, I can't cope. Other people, of course, the pain might be the worst, and some people get a full spectrum of lots of things. We know that migraine can start usually in early adulthood, very, very common in ladies when hormones are starting to kick in as a teenager, and it can continue on for a number of years. And a lot of patients will find things improve. A lot of ladies will find it improves when they get through the menopause, but some people will get migraine lifelong. But naturally, it can sometimes improve with age. And just to reinforce again, I'm speaking to an audience obviously of people who get migraine. You're all aware it's not just a bad headache, and we'll talk a little bit about impact just a bit later. So next slide, please. So it's important to think that, as we said, that this migraine brain is more sensitive to normal life events. It's not that things are happening that only happen to migraineurs. And some of the things that we all are aware of is that the migraine brain is really quite boring, and it likes routine. It doesn't like disruption of routine. It likes regular meals, regular sleep, regular exercise. So disruption, for example, sleep disruption, missing meals, being stressed, and it doesn't have to be horrible stress, just a lot going on and being busy. For ladies, that change in estrogen levels at period time and the fluctuating estrogen levels in menopause, that can be a factor. We know for some people it's weather pressure changes that cause a problem. Some people can identify a dietary trigger, but that's actually quite rare in real terms. The bit of the slide on the left is just talking about headache thresholds. So I always imagine migraine is being like a switch in the brain, and when your switch gets switched on, you get a series of events that happens in the brain that brings the migraine headache and all the other symptoms. And you might have one person whose switch is very, very sensitive, and it takes very little to switch that switch on, whereas you've got someone like myself whose switch is probably not as sensitive as some of yours, and it takes a combination of things. Particularly for me, it's been working really hard and not getting enough sleep. So that's why people can get this variable pattern, and some people will find one thing will trigger them over, other people might be a combination of things, and that headache threshold can vary through your lifetime. So there might be periods of your life where you're more likely to get a migraine. Your brain is more sensitive, and other times in your life where you're not as sensitive. So this is all back to this idea that migraine is this genetic condition, and it's a disorder of how the brain processes sensory input into your brain, whether that's noise or light or smells or weather pressure changes or stress or hormonal changes. So next slide, please. Thank you. In terms of why we get pain with migraine, so I think it's very important to say that the brain itself has no pain fibers. You could take your brain out, kick it around, give it to the rugby team on Saturday, and your brain wouldn't feel anything. So why do you get pain with migraine? So the pain comes from the structures around the brain. And a lot of it will be the nerves that are in the blood vessels that are inside the skull, lining the surface of the brain. And those nerves all start to join together in a big electrical circuit that then feeds back up to the brain. And as those nerves join, it's a bit like my lawnmower at home, our electric lawnmower, where we've cut the cable so many times. We've got a whole series of junction boxes joining the wires together. So you can imagine that this collection of nerves from around the surface of the brain, taking these signals, they join as a junction box. And the picture on the right is a diagram of what the junction box looks like, and it's where two nerves join together, and you have a chemical that gets released by one end of one nerve that will transmit over to the other nerve, and that conducts the electrical signal on. So if we go to the next slide, you can always imagine it's a bit like a Lego block. So you've got the blue bit of Lego releasing the green bit of Lego that floats across the junction between the two nerves, and it has to join into the grey bit of Lego. And how can you stop that bit of Lego floating over? Well, you can either stop it attaching on to the bit of Lego it's aiming for, or you can wrap something around that bit of Lego so it doesn't attach. So when we talk about some of the newer drugs, we're talking about a chemical called calcitonin gene-related peptide. I'm sorry, it's the scientists like these big long names, but it's called CGRP for short. So you can either block the chemical itself, or you can block the bit the chemical attaches onto. So that's kind of a representation of what's happening in the joining bit between the two nerve endings, just like my electrical cable on my lawnmower. So we go into the next slide, please. And this is just a bit more scientific version of that. So the blue dots are the chemicals that are being released from what's called the trigeminal nerve. And the trigeminal nerve is our main migraine nerve. That's the nerve that supplies the top of your head, your face, as far down to your jaw. So that these chemicals are being released, and you can either block the bit of chemical before it joins into those funny shaped receptors, or you can block the receptor. So some of the injectable treatments that Dr. Duncan talks about block the receptor so it can't join in. There's one of the treatments blocks the floating bit that goes over. And we've got these new treatments called the G-PANTs, which are not injections and they're tablets, and they also block the bit that gets attached into the cell. And Dr. Duncan's going to tell you a little bit more about those medicines in course. But that's just to explain why these new treatments can help. So we know that CGRP is an important chemical to transmit the nerve signal down. It's not the only one, and that's why blocking it doesn't always work for everyone, but it's one of the more important chemicals. So next slide, please. So how do we actually define migraine? So there's a group of experts get around a table every 10 years and they decide what they're going to call migraine. What are the features of migraine to call it migraine? And this international classification first started in the 1980s, and that was when the triptan medicines, and some of you will take triptans like sumatriptan and rizatriptan and elatriptan and amitriptan. And when they were doing the clinical trials of the triptans, they had to decide if you were being introduced to be on a treatment in a trial and the doctor was working in London or Glasgow or Paris or New York, but the doctors all calling migraine the same thing. So they came up with what they felt would represent a migraine. And this is not just a headache, it's a spectrum. And over the years that this has been tweaked. And what you'll see is they're suggesting that you have to have had 5 attacks of this headache, that it lasts 4 to 72 hours, and at least 2 of the characteristics are it's a one-sided headache, the pain is pulsing, the pain is moderate or severe, and the pain is aggravated by activity. And some of you, when you get migraine, will want to sit still or lie down because walking around or moving will be painful. And then you've got to have one of the nausea or vomiting or being sensitive to noise and light. But it's important to recognize this as a research criteria, and in real life, not everyone will tick the box. And I'm sure some of you out there, for example, will have migraine that lasts more than 72 hours. If we go on to the next slide, please. This then leads on to a cycle. Oh, this slide hasn't come up just quite the way I was going to do, but it's to show that there's different stages to migraine. So some people will get a premonitory stage and they know their migraine's coming on. So some people will feel quite upbeat, quite full of energy, but they think, well, right, I know my migraine's coming. Some people can identify that they feel like really quite tired, or they yawn a lot, or they crave food, or they feel fatigue, and that's the sign that their migraine is going to be coming on. The next stage is this aura stage. Now, aura means that you've got a temporary disturbance of neurological activity, and that affects maybe 25 to 30% of people who get migraine. So not everyone with migraine gets aura, and some people don't get aura in every attack. The commonest aura is a visual aura, where you get visual symptoms, but it can affect sensory touch, and it can sometimes affect the motor function, and it can sometimes give this kind of disabling dizziness and things that some people can get. And aura is quite interesting because we think it's caused by a disturbance of electricity across the brain, and I'll show you a picture of that just in a second. You then get into the headache phase, and some people, the headache can build up gradually and things build up over a few hours. But obviously there's some patients where headache can come on really quickly. And what's can be really difficult for people is if you wake up with a migraine. So the migraine's developed through the night and you wake up with a full-on migraine. And Dr. Duncan's going to talk about treatment, and we know if you take your treatment early on in the migraine, it's more likely to work more effectively. And then after your migraine, people will feel washed out and tired and maybe a bit achy. And I always think of it in the sense of your migraine is a brain who's having to work really, really hard. So your brain's using up lots and lots of energy, and then it's washed out hours. So it's like run 2-3 marathons, and then you're exhausted for maybe the day or 2 days afterwards. So we recognize that it's, as we said, it's not just a headache, this whole spectrum of symptoms that people get. And I saw someone at the clinic yesterday at the hospital who's starting to recognize that the symptoms they were getting before their migraine was their warning that their migraine was getting on. And he was finding it quite useful because he can then modify what he was doing. Next slide, please. Just not to give you too much technical detail, but what we think with aura is it's what's called cortical spreading depression. And basically, at the start of the migraine, it's like a wave of negative electricity that goes across the brain. And that's why with aura symptoms, they can be progressive. So some of you might get some visual symptoms that start in the corner of your vision and then move across the vision. You might get numbness and pins and needles that might start in your hand or your arm and work up to your face, or it might start in your face and work down. So because it's this electrical phenomenon, you can get both positive and negative symptoms. And usually for most people is between about 15 and 60 minutes. But again, some people it's a bit longer and some people it's shorter. And most patients with migraine don't get the aura symptoms. Next slide, please. So some misconceptions about migraine. So first we've said about visual auras happening in every migraine. So we know 25 to 30% of people will get that. Students and young doctors are always taught that migraine must be a pulsating pain. But as you see from the classification, you can have a headache that is moderate to severe and aggravated by movement, but it doesn't necessarily have to be pulsating. So some people will say it's like a pressure effect, the head's being squeezed in a vice. Some people get sharp and shooting pains. So it doesn't always have to be pulsing. And the other thing is that people are taught that migraine is one-sided, but in fact, 40% of people, 4 out of 10 people will get pain on both sides. And some people, it will start one side and move across. And as I said to you before, some people will get headache that lasts more than 72 hours. And that's really difficult. You know, the person who wakes up on a Monday with their migraine and they still have it by Friday. Next slide, please. So migraine is obviously really important, and we'll talk about disability, and we know it's the third most common health condition in the world. There's more people in the UK with migraine than things like diabetes, asthma, and epilepsy combined. And actually, about 1 in 4 adults aged 15 to 49 in the UK live with migraine. And if you actually made that a female population, probably between 1 in 2 and 1 in 3 females in reproductive years will have had some time where they've had migraine headache. So a lot of people with this condition. Next slide, please. What's the burden of migraine? So we know, and those of you who live with migraine, those of you who live with people who get migraine will know the disability that migraine causes. So the World Health Organization says it's the second highest cause of global disability in the general population. But if you take women between 15 and 49, it's the most common cause of disability. And I can't think of any other medical condition where you can be completely well, and then the next day you're bedbound for 2-3 days, feel absolutely dreadful, then you're well again, and then that cycle repeats. And of course, that has a massive impacts on people with migraines' ability to function, whether it's things like housework and social activities, meeting friends, childcare, working life, and it can have negative relationships with family and friends if you feel that you're letting your partner down. I remember my wife gets migraine before we married. We were living apart, and I met my wife in Amsterdam for a long weekend, and she had a migraine, and she was in bed all weekend, and it was like Lloyd Cole and the Commotions. A lost weekend in a hotel in Amsterdam. What do you do? Do you stay in the hotel with her all weekend, or you just leave her in the dark room and go out yourself? So it's incredibly disabling. And we know that because of that, mood changes and anxiety disorders are 2 to 5 times more common in people with migraine. Now, some of that is genetic. There's a genetic link that if you've got migraine, you're more likely to get anxiety and depression. But some of that is consequent to the real impact and disability that migraine has on the sufferer, their family, and their friends. And if we go on to the next slide, that of course has a big societal cost in terms of the cost of direct health care and the cost in terms of lost production days. And you get this term called presenteeism. I'm sure a lot of you out there have presenteeism, where you've got a migraine, but you're trying to keep going. You don't want to go home from work, but you know in yourself that your brain's just not functioning as well as it should be. So incredibly disabling. So next slide, please. So how do we understand a migraine? I'm not going to talk a lot about this, and some of you will find diaries quite useful. I personally think diaries can be really helpful for people who are getting quite a lot of migraine, to try and work out how many days a month you're getting headache and migraine, to try and track how often you're having to use medication. We know that if you overuse some of the acute treatments, you can get headache caused by the tablets, and Dr. Duncan is going to cover that. Diaries can sometimes help with associations. Is it related to a menstrual cycle? Are there things that you're doing in your life that maybe a pattern comes out? And there's diaries available on the internet. The Migraine Trust have diaries. The National Migraine Centre have diaries, and we've got a link to all these resources. I think what's also really important is to have an impact, to understand the impact for yourself, and also about most bothersome symptoms. So as I said before, for some patients, the headache might be the most bothersome symptom. I saw a lady at the clinic on Tuesday, and the dizziness she gets with her migraine is her most disabling condition. She's really, really disabled. And we've got to recognize that we don't know the genetic cause of migraine. So we know that cure is not realistic, but what we're trying to do with all treatments is to reduce severity and frequency, and then having acute treatments that will make a difference to get someone back functioning. So next slide, please. Migraine triggers. So there's a lot of misconceptions about migraine triggers there. So students are still taught, oh, it's chocolate and cheese that trigger migraine, and actually very few people find an absolute food trigger for them. Alcohol can be a trigger for migraine. We call it an undeserved hangover. So you've had a glass of wine and you get this bad headache a few hours later or the next day. But if you look at the commonest triggers, they tend to be stress. And as I said, it can be just busyness, not that you're not coping, but you've got a really busy life. And I see that a lot in people who are working full time, looking after children, volunteering at weekend to do things. Hormones, And ladies will get migraine 3 times more often than men because of that hormonal factor. Missed meals, that's a common one in teenage girls, for example, not having breakfast, the low sugar dipping later in the morning, and migraine at lunchtime. Weather, says some patients will find that thundery weather will bring it on. I've seen that with people with flying, where flying can be a factor, the sleep disturbance. But there's other things. Perfume, I've got a colleague who can't go in a lift because if they go in a lift and exposed to perfume or aftershave, that sets them off. Really interesting about migraine triggers that there's been a lot of work done on what happens in the brain before a migraine, and Dr. Phil Holland, who's one of the researchers at King's, is doing a lot of work around that field at the moment. But there's been studies done where people have had scans of their brains done every day. So this take patients who have migraine and scan their brains every day. So it's not a structural scan like a CT or an MRI looking for a physical thing. This is a scan that's functional, looking at the hot spots of the brain that are lighting up. And what we know is that the migraine brain is probably starting to change 1 or 2 days before the migraine comes on. So someone has their chocolate on Friday night and blames the chocolate when they get their migraine on Saturday, but actually the brain was already changing on Thursday. And perhaps what some of these food cravings are cravings where the brain's saying, I need energy, I need carbohydrate, because I'm anticipating I'm going to go into migraine. So that's just a useful thing about triggers. We'll signpost you later where there's more information about that. And for example, it's a really good podcast by the National Migraine Centre on triggers that I think it's worth listening to. I'm just looking at my time. Okay, next slide, please. So management summary, lifestyle factors important, and just cover a little bit about that. I'm not going to talk too much about supplements, but there are things like coenzyme Q10, riboflavin, and magnesium that have some evidence in migraine, not a lot of evidence, and a lot of people won't find them helpful, but the National Migraine Centre has and the Migraine Trust have resources on their websites to guide about these things. There are some other supplements, things like butterbur, and things that we don't recommend. There's some evidence that they can potentially be harmful. In terms of acute treatments, Dr. Duncan's going to talk about acute treatments and rescue treatments. So what happens if your standard treatment doesn't work? And then in terms of prevention, we've got obviously tablets, but we have injections where we do injections into the back of the head. It's called a gun block. Some of you will be aware about Botox used and the new monthly injections. And there's also what are called neuromodulation devices. Some of you might have seen, for example, the Cafali, which is like a princess headset that you put on your forehead, and that sends an electrical current. It's a bit like a TENS machine for migraine. And again, some patients find that can be helpful. Next slide, please. So in terms of non-pharmacological, this is just a summary of what I've said. In terms of helping things like sleep, NHS Scotland have access to the Sleepio website. So this is cognitive behavioural therapy for sleep. So some people might find that that's helpful if they're having sleeping difficulties. The Try Daylight's a really useful app, again, helping for anxiety symptoms. Again, that's funded by NHS Scotland for patients. There's chronic pain guides can be helpful. I mentioned a little about the natural remedies, and I think the National Migraine Centre resources are useful for that. And there's a little picture of the Cafali device there, which people can purchase if they want. Again, there's a little bit of evidence for it, not enough evidence to be prescribable on the NHS, but there is some evidence for some patients. And if we go into the next slide, please. Just one final thing. This is one of Dr. Duncan's patients who had been attending hospital and really gone through a lot of the hospital-based treatments that we had. And they were getting Eruanab, which is one of these new monoclonal injections they were giving monthly. And even on the Eruanab, the diary showed lots of headache. We score 0 as a clear day, 1 as a background day, and 2 and 3 are migraine days. So this person was having significant disability. And interestingly, they changed their job. And within 2 months of changing their job, their migraine frequency significantly fell. So for some people, looking at lifestyle can be really important. It doesn't mean we don't have to use preventative treatments, and lifestyle won't help everyone, but there is a big factor there that we need to think about. So I'm going to stop there. So I'm just a couple of minutes late. I'm going to hand over to Dr. Duncan. He's going to talk a little bit more about the treatment options that your GP can prescribe and what we can do at the hospital clinic. Dr. Duncan.
Thank you. You've had coverage of what migraine is. We're now going to talk about treatment. And we'll talk about acute treatment, give you some very practical tips on how to use it. Preventative treatment. So acute treatment is treating the headache there. Preventative treatment is reducing the number of headaches and reducing the chance of getting headaches. And we've got primary care treatment, so the standard treatments we've had for quite a long time, and I'll go through those. We've got some more newer targeted treatments, some of which are new tablets and some of which are injections, and I'll talk through those. Dr. Watson mentioned the gone blocks. So gone blocks, rather than being true preventative treatments, we use these for some people where the migraine's gone on for a while and has become a problem, and it can sometimes help to switch you back into a better place. So we call that transitional treatment. So gone blocks, the injections to the back of the neck are used for that. I'm not going to talk about the devices, but if there are questions about the devices in the chat, we can always take those. So next slide, please. So this is our summary of treatments. So a lot of these treatments are very well established, they've been around for quite a long time, and targeted correctly, they can be quite effective. So we've got simple things like paracetamol, non-steroidals, we use ibuprofen as primarily, aspirin and triptans. And there are a number of triptans, there's 7 of them. Some of them are short-acting, so sumatriptan, almatriptan, elatriptan, rizatriptan, zolmatriptan. And some of them are longer-acting, so frovatriptan. So if you've got a longer headache, then frovatriptan can be potentially useful. So choosing different triptans can be helpful for people. The different treatments have different effectiveness. So paracetamol is quite a mild treatment and usually will only be effective for milder migraines. Non-steroidals and aspirin are effective for mild to moderate headaches, and the triptans are for moderate to severe headaches. When we're using these treatments, we want to use a decent dose. So your ibuprofen comes in 200 milligram tablets, so that generally is not helpful. So we use a high dose at the beginning of the headache, and so that's 400 to 800 milligrams of ibuprofen, depending on how it works for you. Aspirin is 900 milligrams, and these are standard doses, so a bigger dose taken at the onset in order to switch off or reduce the impact of the headache. We can combine treatments together. So if you've a milder headache or your treatment works well, you maybe just use it for one treatment for your headache. If it's a harder to treat headache, then you might combine things together. So there's good evidence that taking a triptan and non-steroidal together can be additive, so they work better together. And triptan, paracetamol, again, are additive. So these can be better effect. Interestingly, the anti-sickness tablets, so cloprazine or Stemetil and metoclopramide, actually have effect on migraine itself. So independently, they can be useful for managing pain, not only for managing nausea. If you do get nausea with your headache, then an antiemetic is a very good treatment to use. And there is evidence that an antiemetic together with a treatment will work better than the treatment alone. And you can combine a non-steroidal and a triptan and an anti-sickness tablet together, and that can work even better. So different people will choose different things. If we combine aspirin and an antiemetic together, it's then as strong as a triptan. So these treatments put together can be quite useful. We've got new specific treatment for migraine. So Dr. Watson talked about CGRP and CGRP blocking treatments. So rimegepant is a CGRP blocking treatment called a GPANT. And we've had a big problem for a lot of years for people who don't respond to these treatments then don't have other things, and people who can't take triptans and then don't have access to a good treatment. The GPANT, rimegepant, is probably about similar in effectiveness to triptans, but can be used in people where triptans are not suitable. So they are a new treatment and are quite useful. If you're taking acute treatment, you want to make sure that you're limiting it to 8 to 10 days per month. We've got good evidence that if you Take more than that, you can make your headaches more and more frequent. And Dr. Watson talked about the migraine threshold and how some people have quite a low threshold for getting a migraine. And we know that some of these treatments reduce that threshold, so they can make it more and more likely to get migraine. So you can end up with frequent headache because you're taking acute treatment too often. And that's an unfortunate problem. And it means that if you're having, say, 4 or more headaches per month, you may be wanting to consider preventative treatment. Now, of course, if you have a really good response to your acute treatment and it works on each time and you get 4 headaches a month, you might just want to stick with that. If it's harder to treat, then preventative treatment is aimed at improving the effectiveness of your acute treatment and reducing the frequency of headaches. Our long-standing first-line preventative treatment is propranolol, which is a beta blocker. That can have some side effects, and it can slow you down and so forth, but it can be very well tolerated and it can be actually quite effective. And the key when we're taking these treatments is to take them at an adequate dose for an adequate length of time, and often you have to build them up. Topiramate is our second line treatment. There are some issues with topiramate now in ladies who are of childbearing years, and we know that topiramate can affect growing baby and can cause a developmental delay. So there are going to be new information on topiramate. We are probably going to be using topiramate less. So if you're thinking about starting a family and you're on topiramate, you want to be off topiramate. Amitriptyline as a tricyclic antidepressant can be very useful, has got old evidence, but for a lot of people, particularly people who have difficulty sleeping, will be quite helpful. We've got nortriptyline that's less sedating and can be useful in people where amitriptyline is more sedating for them. And then for people who have side effects to treatments, candesartan is often extremely well tolerated. That is a preventative treatment for blood pressure and has an independent effect on migraine. So all of these treatments have been designed for other things, but are useful for migraine and are very well established treatments. And we'll talk a bit more about them, but you're generally wanting to think about preventative treatment if you're having a migraine every week or more often than that. Next slide, please. So some tips and tricks for acute treatment. It's important to take your acute treatment early. If you wait until the headache is bad, then it's much less effective. So you need to take it early, but you want to make sure you're not taking it too often so you're not going to get medication overuse headache. So you may have to pick and choose which headaches you treat if your migraine is more frequent. We often start with a single dose of high-dose aspirin or a high-dose non-steroidal. And for people like me, that works really very well. I very rarely had to use a triptan. Most of my migraines are treated very well with 900 milligrams of aspirin. So for some people, that can work exceptionally well, and we often start off with that. For people where that's not effective, you can either have a rescue treatment, so you step up to a triptan, or you choose between different treatments. So maybe for a milder headache, you would use aspirin. For a more severe headache, you would use a triptan. And I will talk through stratified treatment with you in a moment. The response to triptans is idiosyncratic, and what that means is that some triptans will work well for some people, and other triptans will work well for other people. So it is worth moving through different triptans to find the one that works best for you. You don't just abandon it because the first one doesn't work. Of course, there will be some people where triptans don't work at all, but it is worth sequencing through different treatments. And for some people, a triptan will work for a while and then will lose its effectiveness. And a second triptan may work better when it's moved to, and so forth. So it's worth using the triptans like that appropriately. For some people who have headache that goes on for a long time, you can add naproxen, which is a long-acting non-steroidal, and that can lengthen the effect on the migraine. So you use your triptan to start the process off, and you use your non-steroidal to keep the headache away. So that can be useful. And other people with longer headaches, some people would use a long-acting triptan, which just hangs around for longer, and that can be helpful. The antiemetics, as I said, are useful for nausea, and if you are significantly nauseated with your headache, it is worth using because they move treatments through the stomach and help the absorption. So they're helpful for that. They're helpful for the headache. They work in combination with the acute treatment, and so antiemetics are worth considering for management of the headache as well as management of the nausea. The two with good evidence are chlorpromazine, otherwise called Stemetil, and metoclopramide. We now have, as I said, rimegepant. So this can then be used for people where triptans are not as effective or are contraindicated, so they're not allowed to use them. And that would be people with active heart disease, so angina, having had a heart attack, or stroke disease, or people with very high blood pressure, or people with significant peripheral vascular disease. So we wouldn't use triptans in that group of people. Triptans are really still very good, and they're still the gold standard. So rimegepant is about similar to a triptan, but it does give us the option now of another treatment for people where triptans don't work. So it's giving us a better spread of treatments. You need to think about the route. If you vomit within half an hour of having your migraine, then a tablet's not going to work very well for you. You're better with a nasal spray or with an injection. So those will work well. So you think about whether you vomit early. Think about rescue. If your treatment works, but then it wears off, you can use a second treatment within 2 hours. And that could be a different treatment, a stronger treatment, or that could be the same treatment. You need to consider a different treatment if your first treatment is not effective. So if your treatment doesn't work at all, there's no point in taking it again. If it won't work the second time, particularly as the headache will be more established. And so you need to use a different treatment if you're going to do that. So if your aspirin doesn't work, then your rescue treatment is your sumatriptan. And again, just think about how you take the tablets. The melt tablets are no different to the standard tablets. They're still absorbed in the stomach. They're a bit nicer to take, but they're still absorbed in the stomach. Nasal sprays are much more absorbed in the nose, so about 40% absorbed in the nose and then 60% absorbed in the stomach. So they'll get in a bit better, and the injections go straight in, so they don't have to go through the stomach. Next slide, please. So this is when to take your treatment. So ideally, what you do is you take it as the headache is building. So when you know your headache is becoming a migraine, that's when you take the treatment. If you have very frequent headache, and you have headache on more days than not, and you have chronic migraine, so you have background headache days and migraine attacks, you want to make sure you're not taking it on the background headache day, but you are going to take it in the migraine attack. So when is it change into migraine, and when is that headache building up? So you want to take it early, and there's no point in waiting until the headache becomes very severe when you've got all your migrainous features and you're disabled by your headache, because the treatment will work much less effectively at that stage. For some people, it will still work well, and perhaps we would use an injectable treatment or a nasal treatment in that circumstance, but you're better to take it early in the treatment, and often to pick and choose your treatment. Don't take it at the aura stage. For some people that will work, but for a lot of people that's too early. We need to break down something called the blood-brain barrier for the treatment to be effective, and that depends on the headache or the most bothersome symptom coming in. So it's when you, after your aura, that you're going to be taking your treatment. Of course, if your headache builds at the same time as your aura, you can take the treatment then, and avoid waiting until the headache is severe. In order to prevent medication overuse headache, which is an ongoing issue, you want to limit acute treatment to 8 to 10 days per month, or an average 2 days per week. Next slide. And this is stratifying treatment, okay? So most of my headaches are mild to moderate. I get the slowing down, go slow problem, and makes it much less efficient when I get a migraine. So aspirin, 900 milligrams, works very well for me, and I almost only use that. Some people will have only very severe headaches. and you might want to combine treatment for that. So take your triptan and your non-steroidal and your anti-sickness tablet at the same time at the onset. Yeah. Some people are going to have moderate headaches, and perhaps then moderate to severe, then a triptan plus minus an anti-sickness tablet might help for that. And some people will have a mixture of headaches. So sometimes you'll have a not so severe headache, and sometimes you'll have a very severe headache. So you have a variety of medications that you might use for your treatment. So for your milder to moderate headaches, you might use aspirin 900 milligrams. For your very severe headaches, you're then going to use a combination treatment. And often people know what severity of a headache they're going to get and can pick and choose. And if you're one of those people, then a stratified approach can be relatively useful. You'll notice we haven't talked about combination painkillers like cocodamol or Migrelieve, and we've not talked about opiate medications such as tramadol and codeine and things like that. These treatments generally are not helpful for migraine. They do work for some people, but they're more likely to cause medication overuse headache. And our treatments with the non-steroidals, aspirin, triptans, work better in general, cause less issues, and appropriately used are better. So we tend to avoid the opioid and opiate treatments. Next slide, please. So what's a responder? So triptans should be taken at the onset of your headache, take them early. That's when they're going to work best. If the first dose is ineffective, don't try a second dose. It's not going to work. You need to try something different. If there is a response to the first dose and the headache recurs, you can take a second dose of the same treatment. A triptan is not effective in every single headache for everybody. So we would consider a triptan to be effective if it works in 3 out of 4 headaches. So that would be what we would consider to be a good treatment. If a triptan doesn't work, try a different triptan or consider a different route of administration. So take a nasal spray or an injectable treatment, or take a different treatment, or take combination treatment. And when we're thinking about using things like rimegepant, then we want to make sure we've tried the triptans correctly, so we're getting the best out of them. And if you haven't responded to 2 or more triptans, or you have contraindications to triptans, then rimegepant is then a potentially useful treatment. So this works against CGRP. Triptans block the release of CGRP, and rimegepant blocks CGRP. And there is good evidence that they still work in people who have had problems with triptans. Those triptans haven't worked. And they're generally extremely well tolerated treatments. Next slide, please. So medication overuse, I think in my 15 years as a consultant has become less of a problem as people know about this better, but still does remain an issue. So the best way to not get medication overuse is to prevent it. So take treatment 2 days per week, 8 to 10 days per month. And if you're having more than 4 migraines a month, you want to be thinking about preventative treatment. And most people will be in a combination of acute treatment and preventative treatment. And it's any symptomatic medication. So paracetamol even will cause medication overuse headache. Triptans and opioids are more likely to do it, but anything can do it. If we take simple painkillers, it's more than 15 days per month. If it's triptans and combination treatments, it's more than 10 days per month. And we avoid opioids and combination painkillers because they tend to cause more problems. The best way to manage this is to prevent it. If you have medication overuse headache, stopping the overused medication, adding a preventative, or doing both can have a really meaningful effect for people and can work well. So it is definitely worth rationalizing things. And if you're using lots and lots of painkillers, you need to think about this. Next slide, please. In pregnancy, so thankfully, most ladies in the first trimester the migraine will get much better. So it's not a problem for most people. After delivery, when your hormones are kicking back in again, often migraine comes back, but during pregnancy, for most people, it is much better. For some people, it is still quite a problem. For acute treatment, we actually can use acute treatments in pregnancy. So paracetamol is safe. We have good evidence that that's safe. Aspirin we shouldn't use. Ibuprofen is safe in the first 2 trimesters of pregnancy, so before 28 weeks. We shouldn't use it after that. Codeine, this is probably about the only situation we would use codeine. And sumatriptan, which is the most commonly used triptan, we've now got really quite good evidence that it's quite safe in pregnancy and is no worse than not taking any treatment at all. So sumatriptan is actually quite a potentially useful treatment. We just don't have enough information on other triptans, and we don't have any information on rimegepant, so we wouldn't use rimegepant in pregnancy. Next slide, please. Preventative treatment. So candesartan, propranolol, amitriptyline, topiramate are all very well established preventative treatments. If you're having at least 1 migraine per week, or you have less frequent migraines, but they're prolonged and severe and quite difficult for you, then it is worth being on a preventative treatment. Some of these treatments can have side effects, but these treatments are also very well tolerated for quite a lot of people and can have a really meaningful impact for people as well. The important thing is we start at a low dose and we build it up. And that's part of the difficulty with these treatments. It takes time for them to come into effect. So the commonest reason for these not working are you use a small dose or you don't use it for very long. It's going to take some weeks and some months for us to know whether these treatments are effective or not, and we need to get up to an adequate dose, which is going to be different for different people. The target dose for candesartan is 16 milligrams. For propranolol, it's 80 milligrams twice a day. For amitriptyline, it's 50 milligrams at night, and for topiramate, it's 50 milligrams twice a day. If your treatment doesn't work, take it away quite quickly, try the next one. If the treatment does work, but it doesn't work well enough, you can add a treatment to it. And we would usually suggest that primary care general practitioners work through 3 treatments before coming to secondary care. And ideally, we should be doing this in primary care, and we provide advice to GPs on how to manage things appropriately. We think about 50% response as a good response. And for people who've got very frequent migraine, a 30% response can actually be a very, very meaningful response and can allow things to work much better. Next slide, please. So reserve it for frequent and disabling headaches, at least 3 or 4 migraines per month. Start low, go slow, but aim to a decent dose. So if you're not getting side effects, build the dose up. Clearly, if you are getting side effects, see if they settle down. If they're not settling down, it's not the right treatment for you and you want to try something else. Use the minimum dose that works for you, but go up to an adequate dose, and you go to the maximum targeted dose if you're tolerating it and it's not worked well enough yet. You need to try it for a reasonable length of time. Combination treatments can work well. And unfortunately, these things are not cures. No treatments are cures, but we're looking to dampen down the frequency and severity. And most people will be in a combination of an acute treatment and a preventive treatment that can work exceptionally well for people. Next slide, please. So these are some of our newer, more targeted treatments. So Botox has now been established for about 10 or so years. And we've certainly been using it in Aberdeen since 2014. It's given by injections around the head, so 7 injections over your forehead, 4 injections either side, 3 injections at the back, 2 injections in the neck, and 3 over your shoulders. They're generally very well tolerated. People tolerate them usually reasonably well. Side effect profile for the newer treatments is actually much better than the older treatments, so they generally have less in the way of side effects. They're given us 1 set of injections. We reassess things at 3 months and at 6 months. And if they work at 6 months, we carry it on. If they don't work, we move on to something else. If they work exceptionally well, we take a break and see whether you still need the treatment. They also work on pain fibers. So it's not just relaxing muscles, it's on pain fibers as well. And Dr. Watson talked about the trigeminal system and the neck, and it goes over all of these areas. The monoclonal antibodies, these are single injections given usually once a month, but there's one infusion that's given once every 3 months, and there's one injection which is given once every 3 months. In Grampian, we use irinumab and fremunizumab. These are really very well tolerated treatments. Constipation can be an issue. Some people can get high blood pressure with irinumab, and so we get people to measure their blood pressure. Some people can get some injection site reactions, but they're generally well tolerated and they're effective. The effectiveness of Botox and the monoclonal antibodies are probably similar. And for some people, one will work better, and for other people, others will work better. So they're useful, and they're given by delivering them to you. So we've got this home care arrangement. And then the new kids on the block, rimegepant, which we use as an acute treatment, can also be used as a preventative treatment. So potentially these are the first treatments we've had that can be both acute and preventative. And medication overuse headache is probably not so much of an issue with these treatments at all. They're both, again, well tolerated, and they have similar effectiveness to the monoclonal antibodies. So for some people, a tablet is going to be the right treatment, and for some people, an injection is going to be the right treatment. So we'll try and tailor it to the correct person. So a lot of people will be managed by the standard treatments, and these newer treatments are available for use and are quite effective for people. Next slide, please. In pregnancy, it's a bit more difficult for preventative treatment. So we've got evidence for low-dose amitriptyline propranolol. We're better to avoid preventive treatment if we can. Topiramate definitely should be stopped before trying for a pregnancy. So if you are on topiramate and think of pregnancy, you want to be stopped for at least 2-3 months before you try for a pregnancy. Candesartan we shouldn't use in pregnancy. Low-dose aspirin has some potential benefits. So we can't use high-dose aspirin in pregnancy, but we can use low-dose aspirin. These blocks, gum blocks that we talked about, this injection to the back of the neck, they're reasonably safe in pregnancy and would be an alternative for people who are struggling. And magnesium, which has got a long life in pregnancy, again, is something that potentially can be useful for people. For most people, thankfully, it is not an issue, and there's more scope with acute treatments than preventative treatments. Next slide. So what I and other people have been working at over the last little while is to put together a recipe book for primary care, for general practitioners, for pharmacists, as to how to manage headache. Primarily migraine, because most headache is migraine. And this is available now on something called the CSD website for GPs, and we can point them to this. And we're almost to the point where we've got this lovely app, which you can get on your smartphone or a computer, and has the recipe book for how to treat headache, how to treat migraine on it. So hopefully this is something that's going to make sure everybody has got all the right information at the right time, and it is just sort of started, so we're launching that. So hopefully this is going to be a useful way of improving migraine management for people. Next slide. And these are some resources. So there's a sign booklet. The sign guideline is the guideline on what treatments are useful, and there's a patient booklet. So this is helpful to explain treatments for you, and it is reasonably up to date. And then the BASH website has got a patient facing page, which goes through again all these treatments, and will cover what we've covered.
Callum, just mindful of time, the next few slides are resources. I will pop all of the information in the chat if you just want to let everybody see even the resources.
Perfect. Okay, and we'll hand over to Susan and then to Abigail.
Just to Abigail straight away.
Perfect. Thanks very much. So I am Abigail. I'm a community pharmacist that is based in Peterhead at Buckenhaven Pharmacy primarily. So I was just going to go through some of the information that can be accessed by pharmacies. Pharmacies as a whole is got this almost walking off of a street kind of approach, which is really handy for a lot of patients, in the sense that you don't really need to book an appointment. For migraines specifically, some of the treatment that Callum mentioned is accessible by pharmacies, such as your ibuprofen, 400 milligrams over the counter. Your aspirin, 300 milligrams, can come in dispersible tablets, normal tablets. You can also get your normal painkillers like your paracetamol as well. And then also your antiemetic that Callum had mentioned as well, the prochlorperazine. You can get the 3 milligrams buccal tablets, which is the ones that get placed between your upper lip and gum. Those are available over the counter for sale and free of charge through the Pharmacy First service as well. The service itself can provide medications. Sometimes you will maybe need a consultation with a pharmacist just to make sure that you're suitable for the medication as well, depending on other medications that you're on, symptoms and side effects as well that we can go through as too. I was just going to speak ever so briefly on what I've dealt with before with customers and patients. We kind of operate a system that if you get any new medications, it kind of gets flagged up to the pharmacist so that we can go out and speak to you. If you ever have any questions with any medications that you're prescribed, you can always speak to a pharmacist when you're getting the prescription, or come in, telephone, whatever you feel more comfortable with. One of the patients that I had was querying over, she had tried a couple of different treatments for migraines, but had never tried aspirin, and I was happy enough to speak to her and explain to her that this was obviously appropriate enough to try alongside her triptans, that she'd had a couple that had failed for her, that she just had never been suggested the treatment of trying aspirin beforehand. So just as we'd spoken about, that you can sometimes try that pre-headache and see if that'll kind of help as well. And just a 300 milligram off the cuff dose can sometimes be sufficient enough in some people's management of migraines. Another thing that pharmacies can speak about as well is your diary. That I think it was either, I can't remember who was that mentioned it, but the diary planning as well. We can go through some of like your lifestyle tips too, regarding just de-stressing, which is obviously a lot easier said than done, but de-stressing, your increase of uptake of physical activity as well. But yeah, you should try and use your pharmacy to the best of your ability if you can, because first line we are quite good at some things. It depends on what your medical background, your medical history is, because we can obviously refer to the doctor if need be, but it is a good starting point just to kind of get some advice as well. For your kind of, the Migraine Trust has been developing an amazing kind of, just as Callum had said, almost like a recipe book for diagnosing migraines. I've used it for a couple of patients before and I felt quite confident about it. There's some red flags and green flags that we kind of base on patients themselves and how their symptoms can relate to it. For some of the green flags, it would be a case of, are you affected by nausea and vomiting associated with almost like a headache? Is your headache debilitating enough that you're not able to kind of work, you're not going to able to do like your day-to-day life? And then also, is your are you affected by light, or are you sensitive to light as well? That's the kind of main 3 questions that we would kind of ask for if you are a migraine or not. From there as well, we can kind of go down the route of the treatment options that we've got available in the pharmacy, or if we think it's better for you to speak to your GP or the nurse practitioner or whoever is available for you to speak to on that day, or whenever is best appropriate for you. Another thing that's quite good is that you can phone us as well. So sometimes if you are bedbound with a migraine, which can happen obviously, a telephone call as well can be appropriate if you don't feel like coming in face to face. Just phoning and speaking to a pharmacist off the cusp is also really easily accessible too. The main thing that I was speaking about for this is that the best thing that you can do for pharmacy, because we don't have access to your patient notes. We've only got access essentially to the medication that you've been prescribed and that we've dispensed for you. So the best thing that you can do is give us all the information for yourself, in the sense of your symptoms, so that we can tackle it that way and think, oh, it maybe is a migraine, or maybe it's something different. It gives us a much more sense of security for being able to diagnose you as well, and just meaning that we're more confident in what treatment that we can give you and what would be more suitable depending on other medication that you're on or other medication that you've tried as well, because there's no point in you going away with the same medication that you've already previously tried. So yeah, that's basically pharmacy, but use us to the best of your ability if you can. It depends what pharmacy it doesn't depend what pharmacy you're registered with as well. You can phone any kind of pharmacy for advice. You're better just going to your own one, just because they've got a note of some of the medication that you have been prescribed that they've dispensed. But from there, you can easily speak to anyone. It's not necessarily you're connected to just the pharmacy that you have always been to. But yeah, I'll pass over to Katie, who I think is going to wrap up with the question and answering session as well. Okay, thank you, Katie.
Thanks, Abigail. We've had absolutely loads of questions come in, and we won't be able to get through all of those, but I'll ask our panel to pop on your cameras if you can. So David, Callum and Abigail, if you've got your cameras on. And what I've tried to do is pick out questions that are maybe linked to try and see if we can answer a few of those. So the first question that we've got here is asking around, so there's a few questions around this. I'll try and pull it into a couple of key questions together. So it's around the association, if there is any, between migraine and stroke, what the differences are in terms of recognising migraine versus stroke, and also when we should be seeking, or when people should think about seeking emergency care and when not to. So shall I start with you, Callum, on that one? Yes,
so migraine has a small increased risk of stroke. So it's a very small increase. It's more for migraine with aura than for migraine without aura, and there is a small risk of stroke with triptans. But these risks are tiny, 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 tiny. Yeah. So most people who get strokes have the standard risk factors for it. So it's a very occasional problem in migraine, but is not something that we would see really very often at all. Migraine aura, it has positive and negative features. So if you've got visual disturbance, it's tingling, visual disturbance which spreads across. You get tingling up your arm, you get speech disturbance. Yeah. Stroke has negative features, so you lose things, and you tend to lose them immediately. So difficulty speaking, difficulty with weakness, difficulty with vision. Yeah. All happens at once. So actually, for a clinician, it's pretty straightforward to differentiate a migraine aura and a stroke. And sometimes when people get migraine auras in their later life, which is not uncommon, they might go to a TIA clinic to be sure of that. But for most people, it's well differentiated. It's actually a small risk, and it's not something we should worry about hugely. If you get sudden weakness, face, arm, leg, speech disturbance, think about fast, call an ambulance and be seen by that. But that's a different thing.
Callum, I'm just going to add in that migraine with aura gives you a very slightly increased risk of stroke over migraine without aura, and the only clinical significance of that is for contraception. So the combined pill gives you a very slight increased risk of stroke. So you shouldn't have the combined pill if you have a history of migraine aura. In fact, family history and smoking are much more of a risk than either migraine aura as such or the pill. But you shouldn't, that's where I think we'd say if you've got 100,000 people of childbearing age, 4 ladies will get a stroke a year, and that risk will be doubled by aura. So it's a bit like having 5 balls or a bit more in the national lottery. So I mean, I've done the headache clinic now 19 years. I've not yet seen someone with a migraine and a stroke in 19 years. So it is very uncommon. But the key thing is, if you've got aura symptoms, just make sure you're not using the combined contraceptive pill, and obviously don't smoke, and just try and have a healthy lifestyle.
Thank you both.
Katie, can I just add one thing? The other thing Abigail was going to mention is that sumatriptan is available in pharmacies as well. So it's not just your ibuprofen and your aspirin, but the pharmacist can supply sumatriptan as well.
Sorry, I forgot to mention that, David. Yeah, you're right.
No,
Yeah.
you were doing all the other stuff. Thank you.
Yeah, I'll just follow on just briefly. So your sumatriptan is available over the counter in pharmacy on the Pharmacy First Plus Pharmacy First program too. It's the 50 milligrams that is available, but a pharmacist probably will maybe want to have a consultation with you just to make sure that it is appropriate for you as well, just as I previously mentioned. But it totally slipped my mind, which is so stupid because that's the main focus on this.
Oh, don't worry. Katie, sorry.
No, brilliant. Thank you. Well remembered and nice segue there. So just to go back to the question, so just I guess continuing with the theme of comorbidity, there's a couple of other questions similar to the association with stroke that you've just spoken about. So are migraines often comorbid with other neurological conditions? And there's specifically a question around neurodivergence, if there's any association.
So there's a little bit of association. People who have neurodivergence, so autism, ADHD, are probably more likely to have migraine. Again, there's probably a genetic link, but this is not straightforward genetics. It's not, if your mum or dad get it, you've got a 1 in 2 chance to get it. These are our genes have lots of different segments to it, and there's tiny changes in lots of different genes, and this is why we have no cure for migraine as such, because when they've done lots of research into migraine genetics, there's probably 300 or 400 different genes that have slight changes that can be a factor with migraine. So certainly there's a slight increased incidence of neurodivergent conditions, just as you said, you're more likely to have anxiety or depression. You're also more likely to have things like fibromyalgia and irritable bowel and chronic fatigue if you've got migraine. And a lot of what these conditions have in common is central sensitization. So what we mean by that is that this disorder of brain processing of the information that comes into the brain. So the brain finds it more difficult to process that information. So for example, some people who are neurodivergent are more sensitive to say noise or light, just like a migrainer might be more sensitive to noise and light. But so there's probably a genetic link there, but that link is unknown.
Brilliant, thank you. I'm just going to go on to some other questions. There's a few specific questions about maybe more unusual triggers. So I wonder then if maybe the right question for me to ask to pull that together is, can you share some examples of maybe less common triggers of migraine?
I think triggers are, so as we said, the general specific triggers are things that disrupt brain routine. So for example, people who do shift work and eat at the wrong time and sleep at the wrong time are more likely to get migraine. Some people will identify things that are very particular to them. So I had a patient who's very sensitive to tar. So if a road's being resurfaced, he can't go anywhere near that road, and that will set off. So he's very smell sensitive. Dr. Duncan won't mind me saying that he would take a wide walk around Lush, for example, because that kind of smell would set Dr. Duncan off. I'm more traditional things like not enough sleep and noise and things. So some people will find a very individual trigger for them, and that's great if they can identify that. And obviously it's great if they can avoid it, but very often a lot of these things are not avoidable.
And if you think about the triggers, I don't know if you remember Dr. Watson's slide where foodstuffs were down at the bottom and life stress and hormones and weather and all that were up at the top. So actually, individual foodstuffs are more unusual triggers. So you shouldn't go around restricting your diet. If you find a foodstuff that causes migraine or triggers migraine, then avoid that. So they're much less common triggers than the Sando ones. And they can be very specific. Whiskey thankfully doesn't trigger my migraines, but tequila does. So one sort of tequila, bad headache the next day. So they can be quite specific.
Katie, without getting too scientific about it, the idea that you've got these nerve endings around the surface of the brain, for example, in the blood vessels, and constantly sending signals back to the brain. So we think that what happens in migraine is something has made that noise level increase, and the brain's very good at switching off the signals it gets. The brain couldn't cope if it had every single signal that was coming to it. And what happens is that once that noise level increases, it gets to the point where the brain then becomes overwhelmed, and that then sets off this whole cycle of pain. So someone might have something that's very particular to them that just increases that central sensitization, but for someone else, that will never be an issue for them ever. So there'll be funny, bizarre things out there that people will know, but ultimately, that's partly where sometimes where diaries can help people if they can identify something.
That's great, thank you. Another question here around childhood migraine, asking if that's also called stomach migraine or if they're different things.
So when you go, Callum, sorry.
So yeah, it could be called. So essentially, you get various things as you get older. So colic is probably a precursor to migraine. People get little children get dizzy, so the vertigo. Some children can vomit a lot. Stomach migraines, abdominal migraines is pain around the center of the tummy with all the other migrainous features. So my daughter's had abdominal migraine where she just felt sickly and yucky and her tummy is a bit sore, goes and lies in bed because the lights bother her, and 2 hours later she's back to normal. So that is abdominal migraine, and often these things occur in children, and then when you get to puberty, you start to get your headaches, and then you get your headaches afterwards. For some people, some of these things will carry on into adulthood. So there are some people who will still get stomach migraines as part of their general migraine in adulthood. So that can occasionally be a problem, and vomiting can occasionally be a problem for people with migraine as well. But yeah, so stomach migraine, abdominal migraine, yeah.
And Katie, just to add a little bit to that, we know, for example, that patients with migraine were probably more likely to be travel sick when they were children. People with migraines, brains find it difficult to adjust sometimes to travel, so people would have to sit forward. My wife, for example, can't face backwards in a train. She has to always face forward, or you have to be in the front seat of the car, or ironing stripy shirts sets you off, or patterns and rugs and things. And that's why things like supermarkets can be difficult for people, because it's noisy, it's busy, there's lots of movement going backwards and forwards. So there's a whole spectrum to migraine. So we tried to concentrate tonight on the kind of the main features, but it is a spectrum disorder where there's all these other things that can be part of it.
Thanks both for that as well. A couple of questions around overuse headaches. So the question is, and this has been asked a couple of times, if taking acute treatments too frequently can result in overuse headaches, is it the same with preventative treatments if they're taken for long periods? Does that likely to have the same effect?
No, it shouldn't do. Certainly taking acute treatment too often will cause medication overuse headache. Some people do find that the preventative treatment can become less effective, but that's not the same thing as that treatment has caused medication overuse, and you may need to change your preventative treatment. So the preventative treatment should not cause worsening of headache. And it goes back to the interesting one of rimegepant, which is actually an acute and a preventative treatment. So that may be a new way of managing things, perhaps. But medication overuse headache is really a part of acute treatment, not preventative treatment.
Thank you. And there's another question linked to that about CGRP injections. Do they lose their efficacy over time the longer you take them?
For a lot of people, no. And actually, for a lot of people, the efficacy gets better. So we look at these long-term studies, and we can see the migraine frequency actually come down and then come down even more. So for a lot of people, they will continue to work. For some people, like other treatments, they will lose their effectiveness, and we may then need to move on to different treatments. So that is always going to be a problem for some people. But for most people, actually, the effectiveness stays or improves. And with all preventative treatments, if you can get good control and your migraines are much better, then perhaps you don't need treatment in the end, because migraine is a fluid thing. And so, 1 or 2 years down the line, we might be wanting to phase out treatment to see if it's still required, to see if you've gone down into that high threshold to get a migraine rather than that low threshold to get a migraine. So again, that's always worth considering.
Thank you. Another question on medication that Abigail, I'm wondering if this might be a useful one, a good one for you to respond to, asking around triptan tablets in relation to food allergy and trying to find something that doesn't contain dairy. Is that something you're able to give any suggestions on?
I don't know if I'd be able to give any specific suggestions on it, but there is definitely a tool that we could use that I could have a look and see if I can find one out. I don't know if Callum or David would know one off the top of their head that would be non-specific to dairy.
I suppose we as doctors tend to do the prescribing, but I'm not aware of anything particular. But I know certainly our practice pharmacists and our community pharmacists are very good at knowing what are the ingredients depending on which manufacturers. That's the trouble. A lot of these medicines are now what we call generic. So a number of different manufacturers make them. So whilst the medicine's the same in them, the bits that they put together to hold the meds together can be different depending on what manufacturer's supplying it. So sometimes we need to be guided by the community pharmacy, and sometimes the manufacturer itself as to what's actually in what the ingredients are.
Yeah,
so
definitely.
In the first instance, to take that to community pharmacy as a question to get some support on.
So if that's an issue for you, I suppose what you do is you ask the question. You know, as doctors, we don't hold everything in our heads, and we often look things up. So that's a very good way of practicing. And so if that's available in pharmacy, if that's a problem for you, ask.
Definitely.
Thank you. Conscious of time, I'm going to ask one more question and then we'll close off, but I'll just make that reminder that we have been sharing the Migraine Trust helpline because I'm conscious we've had absolutely loads of questions and we can't get through those tonight. So the last question that I was going to pose is, do migraines cause changes on MRI after many years of experiencing them?
So that is an uncertainty. We do see some people with migraine who've got white matter changes, often in the back part of the brain in the cerebellum. And so we do see that for some people. There's an uncertainty as to how significant that is. But migraine is a condition where we have upregulation of normal pathways. Yeah. And so we're not expecting it to cause chronic changes for people. So these little white matter changes that we see in some people, which we recognize more in people with migraine with order, for example, we're very uncertain as to what that means. And often that doesn't actually mean very much in the end. Certainly, if you do, then we sometimes ensure that all your vascular risk factors, your blood pressure and no smoking and so forth, we're more keen to think about that sort of thing. But it's very uncertain whether that is an issue or not.
I think, Katie, just to add to that, migraine's a software issue of the brain. It's not a structural issue. So people who have migraine will have normal scans. We won't find things causing migraine. This is a genetic disorder of how the brain processes that information. So as I said, it's a disorder of sensory processing. It's not that you get more noise or more light. Your brain just has difficulty accommodating that. So it's a software issue rather than a structural issue.
Brilliant. That's really helpful. We'll have to stop there on the Q&A, and I'm going to pass over to Susan, who's going to do some follow-up evaluation questions, and then Rob will close the session for tonight. But thank you to our panel for the Q&A.
Thanks, Katie. So I'm going to quickly share my screen again. Again, if you can scan the QR, that would be great. If you can't, I will pop it in the chat. Just 3 very quick questions. We just want to know what your opinion of tonight's session was, as to how valuable it was to you. So again, we'll give you a minute or 2 and let you fill this in, and then I'll hand over to Rob. Fantastic. Oh, that's fantastic.
Susan, I'll just say that as the people are doing the polling, we have developed an information card that's gone out to all the community pharmacists, which has the QR code and the resource to get links to the Migraine Trust, the National Migraine Centre. The National Migraine Centre, that Dr. Monroe there has a whole series of podcasts on everything that you can think of relation to migraine and headache. So we, for example, we didn't talk a lot about tonight about vestibular migraine, other than I mentioned that dizziness can be difficult for some patients. So for example, there's a very good podcast on dizziness and migraine. There's a very good podcast on hormones and migraine. There's a podcast about lifestyle and triggers. There's a podcast on what a physio can do, and they've got some information again about children as well. So there's the resources card and the ones that the pharmacists have will signpost you to all these various things that are available to give people more information. And certainly as a doctor and a migraine sufferer and a married to a family of people with migraine, I think it's really important for people to understand about the migraine and understand how we use treatments and what people can do to help themselves. So I very much support you all maybe going to some of these resources, and there'll be things there that you'll find quite useful. Sorry, I'll hand it over to Susan.
No, that's fine. Thank you, David. That's really, really helpful. The resources we've spoken about are in the chat, but like David said, if there is anything else, there are information cards with the pharmacists, and if all else fails, the Migraine Trust is an absolutely fantastic resource. Speaking of, I will hand over to Rob, but just a reminder, you'll get an email from Eventbrite with a survey on it. If you can't fill this one in, or you'd like to fill in another one, it is all really, really useful for us to know what is helping you. So thank you very much.